So, Dr. Nightingale, thanks very much for joining us today. Could I begin by asking you a very general question? Why is end-of-life care such an important part of the GP's role?
I think the importance of end-of-life care is that it actually affects all GPs, both personally and professionally. And it's one of the areas of general practice that I think most GPs really feel they want to get right for their patients. We've often known people for a long time. It's one of the strengths of British general practice. And I think to make sure people get a dignified and symptom-free end to their lives, most GPs would see that as a really rewarding part of their work. Why it's important at the moment is that there are quite big changes going on in the demographics in the country. We're predicting a 13% increase in the death rate in the next 10 years or so. And I think most GPs are feeling pretty busy at the moment anyway. End of life care can be quite time consuming if we're going to do it well for a GP. So I think it's an important area that as GPs we manage effectively. And the exciting thing now, I know there are problems with the Social Care Act, but there may be opportunities as well, because maybe we can use our commissioning opportunities to strengthen the services for our dying patients so that we're not overwhelmed, but we can work together with other agencies to provide excellent care for our patients.
And you've now embarked on a 3-year programme alongside Marie Curie to improve end-of-life care in the community. What are your main aims with that?
The main aims are to try and improve end-of-life care. Really, I've chosen as my priorities what the King's Fund has advised GPs to commission over the next 3 years. It was really to give a clear focus to what the work I was trying to achieve. And the 4 areas that the King's Fund say that as GPs we need to help us look after our patients better are firstly services to allow patients to be discharged from hospital rapidly. Currently they can, we know a lot of patients dying in hospital that don't need to be there. They don't want to be there, and it's really too expensive for the health service to sustain as well. So patients are going to be discharged, and a lot of them need to be discharged rapidly. What we can't afford to happen is that late on a Friday afternoon they're just sent out of hospital with no support. So the King's Fund, and I would support this, say that we need to commission services so that the people can get out of hospital quickly, but in a supported way where they're cared for well. So that's the first priority. They also suggest we need a rapid response service for these patients in the community, so that if things change suddenly, say 4 o'clock in the morning, somebody gets pain or something happens, that there is a service that will rapidly respond to that symptom need without the recourse to 999 or an emergency hospital admission, and that will prevent unnecessary admissions for people that don't want to be in hospital. The third area that they would suggest we need is coordinated care. Ideally electronically, and this is called an EPACS, an electronic palliative care coordination system. The idea of that is that if we as GPs have had a conversation with somebody that we know quite well, and they've said, oh, I don't want to be resuscitated, and next time I get poorly I don't want to be in hospital, that can be effectively communicated to the ambulance crews, out-of-hours GPs especially, but also the hospital would know that, so that if they did need to go into hospital for any reason, they could be rapidly discharged. And I think the fourth, but possibly the most important, is that there's availability of 24-hour nursing for patients that want to be at home. Currently, roughly half the country hasn't got 24-hour nursing, and that's a real problem, because through the night, certainly for carers, it's an exhausting time. And so if I could choose one of those, probably 24-hour nursing is a priority. And that's where working with Marie Curie is an exciting venture, because although there are other providers, Marie Curie is got a good reputation when it comes to delivering quality nursing and end of life.
And in terms of for GPs themselves who may not feel that their end-of-life care experience is what it might be for whatever reason. Is there a plan? Is there a plan to improve on training?
There is indeed, yeah. I mean, it's end-of-life care is really interesting as regards general practice, because there are patches of excellent care, better than anywhere else in the world, but there are also areas where the care could be a lot better. And also within GPs, there's a vast range of experience from people that have worked in a hospice. I worked in a hospice for 10 years and learned an awful lot there. And a lot of GP trainees now go through hospices. But there'll also be a significant number of doctors that have hardly done any palliative care. And years ago, it didn't even feature in the undergraduate curriculum. So they could have very little in the way of training. The partnership with Marie Curie is aiming to address that. By setting up a series of workshops and working in partnership to make the availability of education better. We're looking at some innovative ways of improving symptom control. There have been some fairly major surveys in recent times. The Voices survey was a big one that showed that symptom control, especially pain control, could be better in the community. And so we're looking at developing an app that people could use on their smartphones that would be guidance for doses of morphine and conversions, and hopefully that will make the information that you need when you're at the cold face of looking after people. It will increase the availability of useful information to help us look after our patients better.
And is part of the programme to encourage GPs and practices to sign up to the gold standards framework and institute more advanced care planning and that kind of thing?
I'm a great enthusiast when it comes to the gold standards framework. I think it's a tool that can transform the quality of care within practices. So I would always encourage practices to undertake that. Each practice has a choice, but as regards an evidence-based effective way of improving the delivery of care, then I don't think we've got anything better. The other very major theme is better advanced care planning. I think without advanced care planning, we are going to really struggle to deal effectively with the increasingly frail elderly population that we look after. So part of the programme will be to help with training when it comes to equipping GPs with the skills to effectively deal with advanced care planning conversations, because they're not easy. We do know that GPs are in probably the best position as regards patients. Patients prefer to talk about their plans with GPs more than anybody else. But at the moment there are barriers, and I think we're very keen to look at ways of overcoming the barriers that make advanced care planning difficult in general practice as it stands at the moment. But over those 3 years, I'm fairly confident there will be a lot more training available, and there will be structures available to practices to help them record and communicate the advanced care plans better than they've ever done before.
Is this something that could perhaps become a national standard rather than something which GPs and practices choose to take up?
I personally would hope it would become a national standard, yes. I mean, I think it's the only way to shift the way we care for patients from a reactive way of just dealing with them when they get poorly. And then the default position then is often a hospital admission. It would represent a shift to a proactive way of working, which is a much more efficient way of working, of involving the patients, finding out what they want, and hopefully delivering the care to them where they want it, which is usually at home. So I would like to see it become embedded in normal practice, and I believe it will do. It has to. The challenge will be resourcing primary care to do it, because these conversations are time-consuming sometimes, and also sharing the information can be time-consuming. I'm slightly worried that the increasing workload in general practice is making it difficult with the current structures to find the time to have these conversations. That's one of the barriers. And I think one of the challenges that I have is to try and increase the resources available to GPs to hopefully let them have more time with the frail elderly, with the patients that we really need to be having these important conversations with.
The college welcomes the recent independent review into the Liverpool Care Pathway and those recommendations. How are you going to take some of those on board in your programme of work?
Firstly, I have to say I was surprised and a bit sorry to see the end of the Liverpool Care Pathway, because I think it was, in many ways, in general practice, it was a useful document. The positive side of the publicity around it was that it actually may have raised the profile of end-of-life care. So it may be that now we can engage in looking at what replaces it, how we implement it effectively. And so I would like to think, and I'm involved in the process here, that we can develop a replacement tool or something equivalent. I don't think there'll ever be anything quite like it on a national level, but something that GPs will find useful, that will guide practice. And also, just the process of looking at it will make people reflect on how they're currently dealing with end-of-life issues. So there may be an educational opportunity attached to it. I'm hopeful that by early next year, there will be something concrete that we can deliver to GPs to say, look, this is what we'd like to see as the standard of care now. And my plan is to build that into some of the educational events that we're planning for early next year. So yes, I was sorry to see it go. I'd like to see it as an opportunity to maybe move forward with something that's perhaps slightly better, if that's possible. Yeah, we'll see it as an opportunity for learning.
Another key recommendation from the Liverpool Care Pathway review was for the call for a named clinician to take responsibility of every end-of-life care patient. How does that fit with the college's view on restoring responsibility for elderly and vulnerable patients? How are you going to take that forward?
I can fully understand why the review said what they said, and I think a lot of it was prompted by what happened in hospitals where patients were under the care of multiple consultants, and they really didn't know who was taking responsibility for end-of-life decisions. So basically, they didn't really happen. I would like to think, and certainly my view, and I think the college's view, is that most GPs do see themselves as being the key workers when it comes to end-of-life care for their patients. We do tend to know our patients who are vulnerable and frail and have got significant diseases quite well. And most of us are very keen to maintain responsibility. Now, there clearly are problems at times, and I know the standard of excellent care that was proposed from the report was that we give our personal phone numbers to patients and we're available all the time for them. I personally do give my number sometimes to patients, but I think if we were compelled to do that all the time, that would be a problem. My view is that as GPs, we should take responsibility for 24-hour care of our patients in the community. When we're in surgery, we should certainly be the person that patients can call on, and we would respond appropriately and quickly. I think we still maintain responsibility for making sure that the services that are available out of hours and weekends are of good quality and safe, and services that we'd be happy that our families were looked after by. Now, I don't think we can lose responsibility for that. And now we have commissioning power. We really should make sure that the services that are available are of good enough quality. And I think if we do that, and if we make sure that there's efficient sharing of information with electronic palliative care coordination systems, then I believe that as GPs, yeah, we are the main people that are responsible for our patients. We should be the key worker, if you like. But it's unrealistic with the numbers of patients that we have for us to be the person that's available 24 hours a day, every day. But we are responsible for making sure that there's a safe service for our end-of-life patients out there.
So exactly how would that work though in terms of covering during that period out of hours and also just sort of monitoring, keeping an eye on a patient in their last few days?
We can make sure that we share information, so there's electronic sharing of the diagnosis and treatment and the patient's wishes. We can make sure that there are nursing teams available 24 hours a day that we've worked with, and they know the patient, so they will provide a degree of continuity. And we can make sure that if things do go wrong, out of hours, that there is a commission service that will rapidly respond, and they will be all geared up to deal with the needs of that person. So I believe it is possible. In fact, I know it's possible because we've done it in our area and it's working quite well.
But is it a critical issue, the funding, and how to reorganise services to achieve that?
There is, and I think that's where the commissioning dimension of my job is quite important. In a way, I've got an easy role because there's quite good evidence that if you invest in end-of-life care in the community, you can actually reduce costs to the overall health economy because it's much cheaper to have people being cared for in the community than it is in the hospital. So if we can commission services to look after patients well in the community so they don't need to go into hospital, overall we can save money. So it's definitely something that we need to look at, and that's why I'm so enthusiastic about this role and working with Marie Curie. And indeed we're doing a series of workshops so in the next 2 months to all commissioners in England to try and make sure that we don't miss this opportunity to commission good community palliative care services so that we can reduce the use of hospitals for end-of-life care. We need our hospitals to be good and efficient and be good at curing the correctable conditions. We really have to free up capacity so that the hospitals aren't used for people that really don't want to be there and don't need to be there because it's just not an efficient way of using the health service. One of the things that really motivated me to take on this role was the boiled frogs analogy from a chap called Charles Handy. He wrote a book on organisational change. I think he called it The Age of Unreason. And what he said was that if you put a frog into some water and just gradually heat up the water, it won't jump out, it'll just die. And at the moment, unless GPs do something different as regards end-of-life care, we're in danger of becoming boiled frogs because we are going to be facing an increased workload from rapid discharges from hospital and the demographic changes. So we need to look at an organisational change, which really means commissioning better services to support us to look after our patients in the community. Otherwise we're in danger of, well, we're busy enough as it is, but we're in danger of being overwhelmed by some of these changes in the next few years. So,
but GPs who are not yet engaged in commissioning, some of them, some GPs are still finding it very difficult to get involved in commissioning, even if they want to. And we've seen some chairs of CCGs quit because of the workload and the pressure. How can you still encourage people to get involved?
I can fully understand why, when the days are full as they are, it's hard to find extra time to engage with commissioning. My point now, I think, is certainly as regards end-of-life care, unless we engage with commissioning, over the next few years, things could go from bad to worse. So I think we've got a wonderful profession as GPs. I think we are under a lot of pressure at the moment, and I genuinely believe that. I don't want to see colleagues getting more exhausted. A visit to somebody who's dying at home can take an hour or so out of your day. Although the numbers of people we're looking after are going to increase, if we don't engage with commissioning to support us in that work, then we are going to struggle to manage our workloads. If we do have nurses that we can work with, and we have work with hospices and charities, if we have people sharing that burden, I believe we can manage. If we don't, if we keep trying to do things the same old way, I believe as GPs we may struggle, and I would like to protect my colleagues from that.